The Gaston Chair was established quite a few years ago by the Jesuit community in order to bring important and serious Jesuit scholars here to the campus, so that both for them and for the campus we would have this experience of some of the Society of Jesus' best scholarly men. And Jim has been no disappointment at all. He's been one of the most active Gaston professors we have ever had. If you've been around here in the past 2 years, you know that he has been running around everywhere, giving lectures, running seminars, sponsoring debates and discussions, and we're really very pleased by the work that Jim has done for us here this year, and last year as well. Last year, he brought here Bishop Kevin Dowling from South Africa, who spoke on what was happening vis-a-vis AIDS in his country. This year, just a few weeks ago, he sponsored a debate on stem cell research, which I'm sure some of you were at as well. The Gaston lecture last year was on the rights of priests, and this year the lecture is on educating in a time of HIV/AIDS. Jim is a well-known moral theologian. He did his doctorate at the Gregorian University in Rome. And for the past number of years, he has been a professor of moral theology at the Jesuit School of Theology in Weston, across the river in Cambridge, Massachusetts. A wonderful secret, well, maybe it's not a secret, but that I'd like to share with you is that Jim has decided to stay at BC. He will be a full professor with tenure in the theology department from now on, and we hope forever, or at least a long, long time. So just to show you, in addition to all those conferences and seminars I spoke, just since he's been here, he's published 2 books, Moral Wisdom and Works of Mercy. He's a real dynamo and a treasure that we have among us, so please help me welcome Jim Keenan.
Thank you for coming. Before I begin, let me just say that this work that I'm doing, educating in a time of HIV/AIDS, really is a joint work. It's work that I did with Dr. John Fuller. John is a Jesuit. He's also a physician, and he works on HIV/AIDS at the Boston Medical Center. And over the past, I'd say, 12 years, John and I have authored quite a number of papers together. And this is basically his and mine, but we thought it would be a little odd to have 2 of us reading the same paper. On this, just to give you an idea of what I'm doing or what I'm interested in conveying, I'm trying to ask, how do we convey or teach about AIDS today, and what has happened to the disciplines that are engaging this topic? And so I will talk at the beginning about how public health has almost had to rethink its basic conceptual framework. Then I want to turn to how Catholic bioethics has had to rethink its conceptual framework. But in the light of all this advancement that we'll see going on, there still is a lack of a political will to address the problem of HIV/AIDS. And so in the first section, when I talk about public health, I'm going to raise up human rights as the conceptual framework that public health works with. Then when I talk about Catholic bioethics, I'm going to raise up social justice and the common good. And then when I turn to the challenge of the lack of a political will, I'm going to raise up the tradition of the corporal works of mercy, that coming from the Catholic tradition, which eventually I think also we'll see in the more secular world a parallel with the call to compassion. So in a way, my paper is not simply educating in a time of AIDS, but it's learning from the legacies of human rights, common good, and the works of mercy. So let me begin. The paper's about 45, 50 minutes. Then I'll have questions and answers. I know some of you have to leave at any point, so I don't take it personally at all. But I'll be out of here by 10 to 6. Let us consider a fact. Of the 42 million people now infected with HIV/AIDS, India has surpassed South Africa as the country with the greatest number of persons infected with HIV. India's 5.5 million people infected with the virus surpassed last year South Africa's 5.4 million. Here's another fact. In March 2005, the United Nations warned that unless large-scale efforts for prevention, HIV testing, and treatment are put rapidly into place in China, that country will likely count 10 million infections by the year 2010. These statistics, like so many others about HIV/AIDS, makes us realize how much the virus is outdistancing our response to it. If the pandemic is continuing to advance relentlessly, despite current prevention and treatment efforts, we must examine ourselves critically, confronting the world, the church, and the academy by asking how, in 2005, after 24 years' experience, can we be doing so poorly in the face of the pandemic? For those of us who work in educational institutes, we must especially ask, how well are we teaching? This was the central question posed at a plenary session of the 15th International HIV/AIDS Conference held in Bangkok in July 2004 by Dr. Mary Crew of the Center for the Study of AIDS at Pretoria University, South Africa. She asked what educational institutions should do when 42 million people are currently living with HIV/AIDS and an additional 25 million have already died. In light of such obvious failure, can we continue to educate as we do, or ought we to aim at a more transformative model of moral education? In promoting the latter, Crew reminds us that more than a third of all people living with HIV/AIDS are young people between the ages of 15 and 24, and almost 2/3 of these are women. Crew asked, why is it left to young women and girls to bear the burden of the HIV/AIDS pandemic? But as she poses this question in South Africa, those of us in the North are left with another question. How do we in the industrialized world teach 15 to 24-year-olds at a time when their own generation in the developing world is so vulnerable? Crew advocates a way that educators in the developing world and in the industrialized world can collaboratively work together toward a radical overhaul of awareness education so that this epidemic might transform whole school systems for the better. She argues that the values we must highlight are three: social integrity, gender equality, and compassion. I will return to these three values, but for now I want to focus on the relevance of education in a time of HIV/AIDS. As we entertain this question, that is, as we seek to recast our educational institutions so as to transform our cultures and our social structures, we must never lose sight of the primary concern that directly affects our students. To them, Crew says, we need to give a vision that they are valuable rather than vulnerable. I now begin by asking what significant steps have been taken in our respective fields of inquiry, and then I will review outstanding challenges that remain. To begin, where can we find indications of development in educating at a time of HIV/AIDS? When we want to find evidence for effective shifts in educational efforts, it may be more revealing to turn first to students' initiatives rather than to those by their faculty. Students are nimble at recognizing new trends and at subsequently making these trends the subjects of their licentiate and doctoral investigations. Here let me report on several with whom I have worked on issues related to HIV/AIDS in recent years. James Ajaya is a Nigerian diocesan priest whose dissertation, published by the Gregorian University Press in Rome, focuses on the issues of economic justice and gender power dynamics as key concerns for addressing the pandemic. A Peruvian Jesuit finishing his doctorate at Western Jesuit School of Theology, Edwin Vasquez, uses the language of human rights as proposed by the late Jonathan Mann and couples it with the language of social justice as used by his Boston College professor, Lisa Sol Cahill, and asking questions about basic and urgent needs regarding particularly access to patented drugs for already infected people with HIV/AIDS. Patan Mambe, a Jesuit deacon from the Central African Republic, is finishing his licentiate at Weston and has already published his first book, which details comprehensive care for persons living with AIDS. It's entitled Rays of Hope, Managing HIV and AIDS in Africa. His Jesuit colleague from Burkina Faso, Narcisse Nana, has finished a license thesis based on the work of the assassinated Jesuit Cameroonian moral theologian Engelbert Vang, who argues that we need a comprehensive liberating theology to lead Africa out of an anthropological impoverishment stemming from economic and political instabilities. Maria Simperman, an American Ursuline, whose Boston College dissertation is now being published by Orbis Press, proposed a vision of the type of people we ought to become in a time of HIV/AIDS, and central to her claims is the call to be merciful. After finishing 2 degrees in Paris, one in cardiology and the other in moral theology, don't ever think that the heart and moral theology don't go hand in hand, the Egyptian Jesuit, Nader Michel, published his first academic essay discussing the great silence facing HIV/AIDS in his country of Egypt. Most recently, a Cameroonian Jesuit, Azatope Jacquinot, drafted his doctoral proposal using, as Vasquez does, the language of human rights in public health in order to explore the principle of equity in healthcare, but complementing that perspective with the option for the poor as a means for guaranteeing equity. What then are the common threads among these first works of emerging scholars? I suggest that there are 3, and that these 3 are similar to the 3 that Mary Crew offers. First, as Ajaya and Nana illustrate, there is this search, the search for integrity, the search to find an ethical context in which to bring the issues of economic and political instability into the domain of bioethics in general and to HIV/AIDS in particular. The search for integrity is the search to find a gathering context. But second, that search then leads to the question of equity. From Vasquez and Jacquinot, we see that the shift by which theological and philosophical bioethicists are looking to the use of human rights language by public health officials in order to find a much needed, more inclusive approach to bioethics. And they are able to couple this human rights perspective with the Roman Catholic language of social justice from the tradition of the common good. And then third, just as Crew talks about the need for compassion, we see how Michel sees an enormous silence in the face of HIV/AIDS that goes far beyond his beloved Egypt. But we can also see in Mumbe's Rays of Hope and Simmerman's own work a summons to the call of mercy and compassion. These emphases, then, are rather important. That is, to find greater integrity, we must move to the language of equity or justice and the empowering rhetoric of mercy and compassion. Let us now consider how this search for a more comprehensive worldview leads to a shift in analytical discourse that incorporates rights and justice, and then consider the tradition of mercy as an effective response to the pervading silence about and disinterest in the face of HIV/AIDS. The call to have a more integrated bioethics has been motivated by a recognition of the need to produce greater gender, economic, political, and social equity. The ramifications of trying to meet these complementary needs have completely overtaken the field of bioethics, as HIV/AIDS has prompted theological and philosophical bioethicists to rethink their discipline. As a result, bioethicists are no longer primarily engaging physicians as their primary interlocutors, and they are no longer looking to the physician's office or operating room or research lounge as the primary object of ethical analysis and concern. For the first time, discourse with public health officials has become a priority, since contemporary medical ethics is more interested in public health and in major population groups than in particular physicians and their individual patients. If you look right now you will find Daniel Callahan, Norman Daniels, a host of people writing on this new phenomenon. Bioethicists are now talking to public health officials with a degree of frequency and intensity that we haven't seen ever before. This is a shift from the private yet interpersonal to the social and the structural. This does not mean that ethicists do not want to lose their first dialogue partners. It is not that the public health official is replacing the physician, but rather that ethicists now realize a need to be in dialogue with both, with more recent emphasis being placed on the importance of the public health official. Moreover, in maintaining these two conversations, we should not misconstrue that the physician's world is simply a microcosm of the public health official's world. While public health officials approach with the social with insights about demographic patterns and epidemiological impacts, which are fundamental generalizations, the physician counters with very detailed experiential narratives for each patient. But the former is not simply a summary of those later narratives, any more than the narratives are only encapsulations of the summaries. Together, their perspectives, the private and interpersonal, as well as the social and institutional, inform bioethicists as moral educators to have a better grasp on what constitutes human health. Why then turn to the public health official? The turn is due to two main insights. First, the sad awareness that the preventable transmission of infectious diseases, HIV, AIDS especially, is occurring at ever greater rates. We're doing this simply because of the tragedy, tragic immensity of the challenge. But second, that the health of populations, we realize now, is a function more of good public health and socioeconomic conditions than of biomedical advances. Let me read that again. This is Daniel Callahan saying it. That the health of populations is a function more of good public health and socioeconomic conditions than of biomedical advances. This turn to the public health official means that the bioethicist might lose some of the excitement and allure of traditional clinical bioethics. Along with clinicians, bioethicists can also get caught up by our interest in the researcher. The world of the stem cell debate and genetics, for instance, becomes very technologically glamorous. But public health forces us into the ordinary, the routine, the basic. It is what Giovanni Berlinguer calls an everyday ethics, or what Maura Ryan refers to as a bioethics from below. When we appreciate the shift from the clinical world to the public health world, we need to revisit the relevance of the so-called 4 principles of biomedical ethics that Tom Beecham and James Childress have articulated. Those 4 principles are benevolence, non-maleficence, autonomy, and justice. These 4 principles, which are often referred to as the Georgetown mantra, have dominated bioethics for over 25 years. Though they have been claimed to be universally applicable, in fact, they are as local in their origin as in their relevance. They reflect a vision of bioethics that is steeped in American values and which is largely focused on the professional relationship between physician and patient. Why not? This perspective was born of philosophers working next door to their own university's healthcare facility. Thus, benevolence and non-maleficence pertain to particular physicians and other members of the healthcare guild and depend very much on models dominant in our world. In this perspective, autonomy is any patient's fundamental right, and justice becomes a bit of a remainder concept, addressing whatever issues the previous 3 did not. For the most part, in this framework, justice considers whether the physician's particular patient gets fairly treated. Rightly or wrongly, these principles still dominate discussions between bioethicists and clinicians, but they fail when we explore the universe of discourse between bioethicists and public health officials. When we attempt to broach the topic of justice, not with the individual first world physician, but with the developing world public health official, justice becomes not a remainder concept, but rather the basic conceptual framework for the bioethical discussion. When conversing with public health officials, we are by necessity required to consider entire populations their access to treatment and prevention strategies for everyday illnesses that include preventable infectious diseases. Thus, just as public health officials cannot imagine a hermeneutics of the Georgetown mantra as being relevant to their primary sphere of moral education, neither can we. Now we need a hermeneutics that takes us into the world far beyond the clinician's office. This search for a new hermeneutics is at the same time a search for a new language, for language is central to understanding how we conceive HIV/AIDS and the world in which it thrives. As Albert Johnson notes, the public language of AIDS is as important as the science. Together with public health officials, bioethicists are now searching for language that allows them to grapple with issues long since ignored or overlooked. The challenge then is to look not only at the health of the patient, but to the structures that make some persons more vulnerable to this infection than others, at the context that make the transmission of HIV more probable, and at the conditions that assist or hamper persons in accessing information regarding both prevention strategies and treatment. In other words, unless we reflect on the social, economic, religious, and political infrastructures in which people at risk for HIV/AIDS live, there can be no adequate hermeneutics for the ethics of health in the age of AIDS. Three major figures in the battle against HIV/AIDS lead us in this direction. First, Paul Farmer, the physician and medical anthropologist, has consistently looked at the inequity of social institutions and how they embody virulent pathologies of power. Reflecting on the deep connection between poor health and poverty, he sees the root causes of disease as being more connected to economics than to biology. He is particularly vigilant about the structural violence which is frequently visited upon women and children. From a different perspective, global economist Jeffrey Sachs looks at how disease affects social structures. Disease, he argues, makes people poorer. Disease keeps people within a downward spiraling economy. While poverty certainly creates the conditions by which people are at risk for poor health, which is what Paul Farmer argues, Sachs argues disease destroys their ability to escape from the very context that made them susceptible to ill health in the first place. Jeffrey Sachs writes, "Disease is not only a tragedy in human lives, disease is disaster for economic development. The major reasons why many of the poorest countries in the world, particularly but not exclusively in sub-Saharan Africa, are stuck in poverty is that the disease barrier is so great that it is blocking many different normal avenues of economic advance." Farmer and Sachs do not contradict one another. Rather, they keep us on track to see the deep and interlocking connections between poverty and disease. It was this interconnection between poverty and disease, particularly with respect to HIV/AIDS, that prompted Jonathan Mann to challenge the hermeneutical context for doing public health in a world of HIV/AIDS. In 1997, just about a year after, it was a year before that Jonathan Mann spoke here, Jonathan Mann, first director of the United Nations Global Program on AIDS, is a predecessor of what we now have as UNAIDS. Jonathan Mann had the foresight to make the connection between human rights and public health. He did this by first drawing attention to the connection between poverty and illness. The vast majority of research into the health of populations, he wrote, identifies so-called societal factors as major determinants of health, of health status. Most of the work on this area has focused on socioeconomic status as the key variable, for it is clear throughout history and in all societies that the rich live generally longer and healthier lives than the poor. He asked, a major question arising from the socioeconomic status health gradient is, why is there a gradient? In response to this question, Mann reflected on the inability of public health to integrate into a solution what it realized was central to the problem. He writes, while public health may cite or blame or otherwise identify the societal level or contextual issues, It does not deal directly with these societal factors. He then gave 3 reasons for this paradoxical inaction. First, public health lacked a conceptual framework for identifying and analyzing the essential societal factors that represent the conditions in which people can be healthy. Second, public health lacks a vocabulary with which to speak about and identify commonalities among health problems experienced by very different populations. Third, there is no consensus about the nature or direction of societal change that would be necessary to address the societal conditions involved. He concluded by ruling the ineffectual babble that public health officials inevitably uttered without these critical tools. Lacking a coherent framework, a consistent vocabulary, and a consensus about societal change, public health assembles and then tries valiantly to assimilate a wide variety of disciplinary perspectives, from economists, political scientists, societal and behavioral scientists, health systems analysts, a range of medical practitioners. Yet while each of these perspectives provides some useful insight, public health becomes thereby a little bit of everything, and thus not enough of anything. Man appreciated in the language of human rights its integral comprehensiveness and its moral urgency. That is, human rights language could link global campaigns for the right to access available medical treatments with equally effective and strategic movements to obtain greater equality in political, economic, and social forms of life. He therefore proposed that public health had a desperate need for the conceptual framework of human rights to analyze and effectively respond to the unprecedented nature and magnitude of the HIV/AIDS pandemic. What tangible changes have resulted from this language change? Let me just give you 3 tangible changes that have happened because of using the language of human rights. First, in July 2001, the Declaration of Commitment on HIV/AIDS at the United Nations General Assembly Special Session on AIDS provided public health officials and AIDS activists with a common language of discourse to be used not only by the Surgeon Generals or Ministers of Health of particular countries, but also with their kings, presidents, and prime ministers. The language of human rights, as conveyed in the Declaration of Commitment on HIV/AIDS, provided a bridge between the political and the medical. Second, this linkage of disciplines led to another building of bridges, imagining access for all and eventually conceiving access for all as a moral imperative. Let me just very briefly do this. Let me show how this bridge was built. A bridge to say that access to treatment should be an access for all persons to treatment, and that that access should be a moral imperative. In 1996, we were able to develop the now famous antiretroviral treatment that brought hope to patients in the industrialized world. That was in 1996. Thus, in 1998, at the International AIDS Conference in Geneva, they held as their theme, Bridging the Gap. But there, only AIDS activists challenged the healthcare community to imagine the possibility of treating already infected persons from the developing world. At Geneva, these activists were opposed by many who claimed that antiretroviral therapies were really only appropriate for the industrialized world, arguing that developing world patients' inability to find appropriate water and to understandable times of administration made provision of these drugs completely unimaginable. Thus, despite its theme, Bridging the Gap, the Geneva meeting became known as the Conference to Mind the Gap. By the Durban International AIDS Conference 2 years later, in 2000, public health officials and clinicians faced the once unimaginable. It was there that the question of universal access would finally be brought to center stage. Peter Pio, Executive Director of UNAIDS, opened the conference with these words: We are hearing and heeding the ever louder call of people living with HIV to place the issue of access to treatment at the center of the world's moral agenda. Let this be the conference the world remembers for solutions, for mobilization, and for breaking the silence. That building at the bridge leads then to the third point. At the 2002 Barcelona International AIDS Conference, concrete proposals for drug access were finally being proposed by public health activists, economists, government officials, and UNAIDS. Successful programs in Thailand, Haiti, Costa Rica, and Brazil were specifically studied and invoked as examples of normative solutions. Paulo Teixeira, for example, of the Brazilian STD AIDS program, explained why and how his nation came to the decision that antiretroviral therapies should be made universally available to all HIV-infected persons, and singularly credited the language of human rights as the cogent means for validating the policy. He said, "What we have been doing is putting into practice principles that have long been recognized by the international community. At their very core is the Universal Declaration of Human Rights, adopted more than 54 years ago." Certainly there continues to be debate about human rights language. Whose rights? How are they articulated? How are they applied? Who guarantees them? And invariably, who determines the answers to any of these questions? Nevertheless, in responding to these central issues, it is precisely the vocabulary of human rights and its conceptual framework that allow these critical discussions to occur and makes possible the development of coherent, equitable, and effective policies for HIV prevention and treatment. We cannot imagine that achievements attained thus far in responding to the pandemic could have been possible without this shift in conceptual framework. Its effectiveness has been proven, and for this reason, we believe that it is a key asset in the armamentarium of moral educators for teaching about and responding effectively to our world infected with HIV/AIDS. The language of human rights provides us a way to communicate within and across disciplines, not only to analyze properly the socioeconomic conditions relevant to the transmission of HIV, but also to forge consensus and to galvanize the political will to eradicate effectively these conditions. As mentioned earlier, Catholic theological ethicists and bioethicists have paralleled these developments, and I just want to do this very briefly, by bringing the language of the common good, social justice, solidarity, and the option for the poor into their discourse. This again arises from the shift of interlocutors, from the shift in focus, from the shift in context, and from the shift in language. In many ways, Lisa Sol Cahill pioneered this shift, and colleagues and students have appropriated her initial insights and subsequent developments. The new language of Catholic bioethics engages the traditional language of Catholic social justice, at the same time that it makes the former more social and more attentive to issues of power and distribution of resources than was previously held. In a word, our language helps us to bridge the gap between conceptual analysis and social change. We do this because bioethics must be effective. Like public health officials, we need to realize that questions of vulnerability to disease and access to information and treatment really need to be understood in their social settings. We cannot make the claims of what is fair unless we have the linguistic instruments to understand why there are inequities, or to use the language of man, why there is the gradient. Concomitantly, we need to recognize that just as those on Catholic bioethics were turning to the Catholic social tradition, simultaneously, those writing on a sexual ethics in a time of HIV/AIDS made a similar shift. Here we can think of authors from Europe and Africa, like Kevin Kelly, Stuart Bate, and Paulinus Odazor, who have seen in the Catholic social tradition an important resource for developing a just sexual ethics that appreciates particularly the importance of gender equity. Here then we can see an integration of Catholic bioethics, social ethics, and sexual ethics long looked for over the past 100 years. All these efforts, though, lead us to the second, and only second, very disturbing question. If we have been developing the tools of analysis for ethical action, and if ethicists, along with those from the medical and public health communities, are working to respond to the plight of those affected by HIV/AIDS, why is this pandemic still outdistancing us? I want to suggest, as was repeatedly pointed out in Bangkok, that the fundamental problem is not a lack of resources that could be appropriately directed, but rather a lack of political will and leadership that makes such commitments possible. This lack of political will seems at times to be sheathed by a fearful protectionism more interested in its own moral integrity than in the welfare and survival of those most threatened. Right? So my argument is that I believe that this lack of political will is sheathed by a fearful protectionism more interested in its own moral integrity than in the welfare and survival of those most threatened. After fleshing out this argument, I will conclude by comparing this interest in preserving purity with a contrasting historical example: the relevance of the works of mercy as they were lived in Europe at the end of the 15th century in responding to the outbreak of syphilis. Several key claims point to the strategies by which stable populations are in effect quarantining themselves against the virus and against the values, or lack thereof, that they identify with the virus. First, HIV/AIDS is perceived as a multi-layered threat, an insight that cannot go unmentioned. At a first level, because HIV is an infectious virus, every society self-understanding finds it necessary to perceive the virus as inevitably coming not from within their society, but from outside of it. The first person in any society to contract the virus had to have acquired it from a member of another society. For this reason, as it is true in the history of syphilis, one repeatedly hears about the entry from outside of HIV/AIDS into any culture, and of the need to document the foreign source of these origins. Second, the virus particularly thrives where there is instability, a notion that we believe is extremely important. Those who are viewed as being marginalized in any society are commonly described as those most at risk for acquiring HIV infection. But I would contend that this characterization doesn't quite get at the core of vulnerability to becoming HIV infected. HIV/AIDS breeds specifically where there is social instability. Whether that means those who are affected by civil strife, military incursions, or liberation armies in Uganda, Haiti, Sudan, or the Congo, or those who are refugees in any part of the world, or those in the prisons, say, of Russia, or those married to South African or Indian truck drivers who themselves live in very unstable worlds, or those in debt-ridden nations on the verge of economic collapse, or those heads of families forced to emigrate for employment, and those at home who await them, those who are drug addicts, whose own self-apprehension is itself unstable, those who are forced into sexual activity to support their children, their families, or their school fees, those who are overseas workers and fishermen, those who engage in clandestine homosexual activity in homophobic societies, or those girls and young women, as Nicholas Kristof wrote this morning in the Times, who are faithful to their marriages or to other stable sexual relationships, but whose husbands or partners put them at risk because of external sexual liaisons. In short, if we want to find persons at risk for the virus who already are infected by it, they are not simply marginalized people. They are people who are vulnerable precisely because their lives and their social settings lack the stability needed to live safely in a time of HIV/AIDS. If you understand this claim, then hopefully you're beginning to understand the perniciousness of a society that creates barriers against these populations. Jeffrey Sachs, in the recent Time magazine essay that he wrote, emphasizes the importance of this concept of instability when he writes, "Since September 11, 2001, the U.S. launched a war on terrorism, but it has neglected the deeper causes of global instability. The nearly $500 billion that the U.S. will spend this year on the military will never buy lasting peace if the U.S. continues to spend only 1/30 of that, around $16 billion, to address the poorest of the poor, whose societies are destabilized by extreme poverty." Similarly, Peter Pio argues, a first and crucial way in which the AIDS pandemic is exceptional is that it is an epidemic equilibrium is nowhere in sight. Not globally, not at the level of epidemics in most countries, and not over the long term. This instability or lack of equilibrium is a chaotic world in which the very structures needed to fight the virus are lacking. Third, against this threat of instability, our more stable societies and institutions, including churches, have attempted to create protective barriers. Again, Pio reminds us that the barriers to prompt and effective action are immeasurably magnified by taboo, denial, and prejudice. This strategy is remarkable because in an almost perverse way, these defensive barriers on the part of leaders in strong, stable cultures are antithetical to the attempts of ethicists, public health officials, and clinicians to keep the most vulnerable uninfected. As opposed to supporting those public health preventive strategies which protect HIV vulnerable individuals, some leaders and members of their societies perceive that the better and more important shields are those that keep risky individuals distant from the general population. For instance, on April 20th, 1998, the Clinton administration declined to lift a 9-year-old ban on federal funding for needle exchange programs, despite the finding by government agencies that such programs effectively reduce HIV transmission, do not encourage drug abuse, provide a bridge to general medical care and to drug treatment and detoxification, and ultimately save lives. But General Barry McCaffrey, then director of the White House Office of National Drug Control Policy, actively urged the administration not to lift the ban, saying to do so would send the wrong message to our children. As public servants, citizens, and parents, he said, we owe our children an unambiguous no-use message. Though researchers and major newspapers endorsed needle exchange programs, though supportive arguments from religious and ethical sectors were subsequently offered, McCaffrey's protectionist argument of our children and our public image won the day. That is, even though the scientific studies and moral principles were able to defend needle exchange programs, the chance that a mixed message might be heard by our youth living already in stable societies trumped any other argument. In this way, the United States, allegedly in the name of morality, created a barrier which isolated the unstable world of drug users from the rest of society, and from interventions that could have saved the lives of drug users themselves, and also of their sexual partners and of their children. Unfortunately, this and other barriers are not uncommon and can be seen in many countries where citizens can identify those most at risk for HIV infection as those that already threaten society's values. Fourth, this isolation is also often backed up by a deep moral judgmentalism, whether explicitly stated or not. Donald Messner, in his new book, Breaking the Conspiracy of Science, Christian Churches and the Global AIDS Crisis, examines compelling data from the HIV/AIDS pandemic and finds a church leadership that stands pathetically aloof, righteous, and judgmental. He appeals to several surveys to back his argument, among them an informal one taken at the World Council of Churches gathering in Harare, Zimbabwe in 1998, in which 68% of those participating in the World Council of Churches said that they believed the pandemic to be a punishment from God. Only 48% were willing, as leaders, to respond to church members with the virus. We're not talking about prevention, to respond to persons with the virus. 48% were willing. and only 25 would educate youth about related issues of sexuality and drug use. This morality of exclusion, moreover, identifies as morally compromising and not clinically helpful the very instruments which have in fact been shown to be capable of providing HIV/AIDS protection: condoms, needle exchange, and more than just abstinence-based education. Just as some people believe that unstable individuals need to be cordoned from society, so too they believe should these instruments. For this reason, any society that tolerates or welcomes these instruments is perceived as putting their own population at risk. Fifth, moral judgmentalism depends powerfully on the capacity to blame. This blame is deeply tied to the belief that those living in unstable situations cannot be trusted and ought not to be admitted to the stable inner circle of society. Moreover, since their condition is in many cases presumed to be their own fault, it does not merit the sympathetic and supportive response that occurred, for example, with the victims of the Indian Ocean tsunami. The biblical tradition of Job, whose narrative contradicts the deep-seated belief that we are the authors of our own troubles, apparently has no claim here. Attempts to humanize those already HIV infected by illustrating that almost anyone can get HIV appear to have had the opposite effect. For example, though the infections of famous innocently infected Americans such as Ryan White, Arthur Ashe, and Elizabeth Glaser tangibly convey that anyone could become HIV infected and that blame is therefore inappropriate, still their stories led many to believe that we must, as a result, be all the more protective of ourselves against the threat, distinguishing the innocent infected from those who are blameworthy. Thus, the face of AIDS is rarely perceived as being innocent. The face of AIDS is rarely perceived as being innocent. This attitude can be seen all too well in the offhand comment of a good friend of mine, a law enforcement official, who when I was telling him about my paper commented, "I equate AIDS patients with the prisoners I have in my cells. I see them as a threat." Rather than being able to identify with the HIV-infected person, we become more convinced that, like Ryan White's playmates, we must keep our distance. Sixth, silence is frequently integral to a strategy of protecting orthodoxy and is particularly problematic when questions of sexuality are addressed. Public health officials remind us that, if anything, we need to more directly and clearly bring discussions of sex and sexuality into the open. However, HIV protection programs that only permit discussion of abstinence can actually put adolescents at increased risk for HIV, other STDs, and pregnancy if and when they do initiate sexual activity. One recently cited study of 12,000 young people suggests that while those taking sexual abstinence pledges indeed delayed initiation of intercourse by an average of 18 months, 88% still went on to have sex before marriage, but only 40% of pledged males used condoms when they eventually had sex, as compared with 59% of those who did not take the pledge. What does breaking the silence afford? At the Bangkok HIV/AIDS conference, studies of men who had risky sex with other men and then later with unknowing female partners were reported from Africa, India, and the United States. Two other panel presentations broke a long-held taboo by disclosing male homosexual practices in Africa. This led in turn to the question of whether an HIV-infected person had a moral responsibility to inform his or her sexual partner. Now, that may seem like an easy answer to that question, but you don't ask the question if you don't discuss the case. By thus bringing these sexual practices into the open, people were able to discuss the challenges to prevention strategies. When the question, what do faith-based organizations need to do in the face of HIV/AIDS, the leading theologian at the conference, Musimbi Kanyoro from the YWCA, was posed this question, and she answered, break the silence on sex. What can the faith-based communities do? They can break the silence on sex. they have the hold on the silence. What we see in this sixfold strategy, then, is not merely a lack of political will, but an actual active resistance to any real engagement with root cause issues. This resistance is based on deep-seated fears of becoming contaminated at a variety of levels and occurs among citizens as well as church people and also the leaders of both. When we compare this isolationism with the developing strategies of ethicists, public health officials, clinicians, and researchers, we find a gap between these two mindsets as broad and as deep as the gap between those at the highest risk for acquiring HIV infection and those seeking to be distanced from them. If bridging the gap is what we must do, how do we do it? First, we must advance greater dialogue among advocates of these two very different strategies. Through education and respectful conversation, we must find appropriate means to build common ground and especially to name and to raise up as models effective bridge builders. Here, I think, especially of the work of the Catholic Fund for Overseas Development of the Bishops of England and Wales. It's known as CAFID, which through its brave and well-argued attempts to confront the contemporary Catholic tendency to retrenchment and purity has offered what the risk of mercy means. Or of Yale Divinity School's Margaret Farley's initiative to create opportunities for discourse between women from the United States and women from Africa so as to address the pandemic. And finally, I think of who spoke here last year, Bishop Kevin Dowling's relentless efforts to move his brother bishops in South Africa to endorse effective prevention strategies and to promote a healthy and realistic discourse on sexuality. These three are instances of effective bridge builders with those who are afraid and are creating resistance and those who are saying we need to bridge the gap. In his attempt to bridge the gap, Donald Messer confronts the Church's need to advance AIDS prevention. He specifically challenges us to ask whether the messages of mercy, forgiveness, and compassion have been compromised by an agenda driven by purity, law, and judgment. Messer argues that not only is the welfare of those at risk for HIV infection being threatened by these approaches, but that the very integrity of the Christian character is also being jeopardized. Messer insists that AIDS is not a dirty word and exhorts us to follow the example of Jesus. He outlines and examines 7 stages to a platform for a call of age, for a call to action. First, a challenge the sexual practices of men, to provide behavioral change education for men and women, to reach out to the most impoverished women, to reject patriarchal structures of church, to champion human rights legislation and eradicate gender inequalities, to help women to protect themselves against HIV/AIDS and receive proper health care, and to protect the well-being of children. Echoing both Mary Crew and the eminent Irish moral theologian Enda McDonough, British moral theologian Kevin Kelly has proposed a new theology of AIDS and of sexuality that will reawaken us not only to the needs of those infected or at risk to becoming infected, but a need to reawaken the very kenotic essence of the church. Toward that end, of reawakening the very kenotic essence of the church, we need then to draw our attention not only to those at risk, but also to those who create the barriers which exclude those at risk. We must remind them that for their own sakes, they must bridge the gap. That this is what the Gospels command, whether in the Last Judgment of Matthew 25 or the Luke and Good Samaritan parable. In these and other instances, Christ's fundamental command is to be merciful. And as we see in the Good Samaritan story, the call to be merciful often requires us to sacrifice our desire to maintain purity. What is mercy? I describe mercy as the willingness to enter into the chaos of another. Moreover, as a virtue, I believe it embodies the heart of Catholic moral education. On this note, then, I close by commenting on the Church in Italy, in its merciful historical response in the face of another dangerous epidemic, transmitted through sexual relations, the syphilis epidemic at the end of the 15th century. I just want to tell you a little story and end on that. In 1497, the Compagnia del Divino Amore, the Confraternity of Divine Love, was founded in Genoa by the Chancellor of the Republic, Ettore Venazza, as a group of laity and clergy committed to working for those suffering from shame, the poor, the prostitute, and the syphilitic. So this confraternity was started in Genoa, 1497, specifically to care for the poor, the prostitute, and the syphilitic. But by 1498, syphilis is just rampant throughout Genoa. Victims of a great port city. Victims of syphilis, having been abandoned both by their families because of shame and by hospitals because of fear of contagion, found a welcome in the confraternity's hospitals for the incurables, as they were called. In 1499, they built the first hospital for the incurables in Genoa. In 1510, St. Gaetano built a hospital for the incurables in Rome at the Church of St. James on the Via Flaminia, so as to care for the pilgrim who fell victim to syphilis on the pilgrimage to Rome. It's true. I mean, it was built for people who were on pilgrimage who contracted syphilis. So think of the pilgrimage. Who contracted syphilis on the way to Rome. And rather than judging them, they welcomed them into the city of Rome with a hospital for the incurables, 1510. In 1517, the confraternity built the Hospital of Mercy in Verona. Shortly thereafter, Gaetano went to Vicenza to reorganize the Hospital of Mercy in Vicenza to serve the syphilitic. In 1521, the Hospital of the Incurables was opened in Brescia. In 1522, Gaetano opened a hospital still standing today in Venice. In the same year, a confraternity chapter is founded in Padua, and within 4 years, they opened the hospital for syphilitics. In 1572, a hospital opens in Bergamo, and in 1584, another in Crema. As did Christians in the early 16th century, we also find ourselves confronted with an incurable disease. No one today remembers the narratives of those who excluded the victims of syphilis, by establishing physical or social barriers of protection based on moral judgments of blame. Rather, history teaches us about the self-understanding of those who realized they were compelled by Christ's demand for mercy to identify with the burden of those at risk and to provide them with effective relief, comfort, and companionship. They welcomed the incurables into their more stable world. As educators in a time of HIV/AIDS, we are learning to appreciate the critical importance of attending to the concepts of justice, human rights, the common good, and the option for the poor. If we can be faithful to the need for a broadening and deepening of our approach, assuredly we will be able to develop a more competent and comprehensive strategy that encompasses bioethics, sexual ethics, public health policy, and medical care. Similarly, by retrieving the lessons of mercy, we might be able to coax those who are afraid and entrenched in isolation into extending their hands and their resources from their firm and stable centers of faith and morals to those who live unstable lives in unstable settings. That movement, animated by mercy, is certainly what we need today, not only for those living in chaotic lands, but just as importantly, for those living in the stable ones of faith and culture. Thank you. Why don't we just take questions or I hear comments for about 10 or 15 minutes, and as I said, we'll adjourn by 10 to 6, the latest. Maria.
I'm wondering, in your example of the syphilis in Italy, I could easily interpret that as the creation of hospitals which then isolate those victims. It's not clear to me that they're necessarily entering, you talked about mercy, it's entering into the chaos of another. And in the way that you describe the HIV/AIDS pandemic, it's more than just creating hospitals or hospices for those who are actually in the process of dying that then sets them apart. I mean, we do have those. But that doesn't sound to me like it's the kind of,
I think the first step of real mercy today would be somehow to bridge the gap, not just between those who are at risk and those who aren't, but between those who are in isolation and fear and those who really believe that we need to be in greater dialogue and greater discourse with those who are at risk and to find those structures. I think that the merciful disposition of those who are already in isolation would be simply to enter into dialogue, to break the silence, to say that what their real fears are. Inevitably, when people finally feel that there's safe ground for them to speak about their fear, we get further. But where is the context for having that discussion? And it's a discussion that's urgently needed. But it is so manipulated. If you just do a study of the United States' refusal to have any federal funding for needle exchange programs, what you see is simply a pounding rhetoric that says we can't mix the message. And it's very hard to get to that fear behind all that don't mix the message. Because not only is there fear there, but there's a lot of power, there's a lot of money, and there's a lot of control of the discussion. But I think that if they were willing to just break the silence and to enter into discourse, the possibility of finding the opening would be a significant merciful. They would be willing to enter into the chaos of the situation. So, I mean, but I'm using the syphilitic issue to show how people did not give up on trying to develop these centers. Do you know in the beginning they were all, their identity and their confraternity was secret. No one wanted their names to be known. So to be involved in working for the syphilitic was a real break with your own society. So you were a member of the confraternity of divine love. You took a pledge to protect the secrecy of the members there. So it was those people, and that's what I'm trying to say, is that we don't remember the narratives of exclusion. We do remember the narratives of the reaching out, and trying to use those narratives positively to invite people to respond. That's what I think we need to revisit. So I do mean it, not an exact model, but an analogous model of how they try to do it. What do you think of this thing about my response to you?
I think it sounds to me like the issue is the fear of mixing the message.
Right.
And I mean, I can see that in kind of our political discourse and across the spectrum. And so that seems to me kind of a fundamental question of, you know, for instance, are our youth, in the question of abstinence-only sex education versus non-abstinence only, the fear I have often heard in conversations is if you talk about the using a condom or some kind of birth control, all of a sudden you're legitimating sex. We're mixing the message when what we really want to say is wait.
Right.
Well, so part of it is, my reaction to that is you're underestimating the intelligence and the ability of people to be able to sort through a mixed message.
Right.
And so how do you, I guess,
And we're in the year 20, I know, I mean, here we are, we could talk about human rights, we could talk about all these conceptual analyses. We can't get to the fundamental thing of having a discourse on sex, or having a discourse about our fear, or having a discourse about mixed message. We live, you know, you turn on the TV set and there's plenty of mixed messages. Nobody has any difficulty with that, but let's not talk about what's happening in our lives. This is what's really striking about the culture we live in right now. I mean, we can look at the affair that's happening in Florida. You know, just how people really are deeply concerned about values and how they rally around seeing what they think is, or what they perceive as the threat. And that's why I did the paper. We need to surface the constitutive elements that make that perceived threat into an active resistance to responding to the plight of HIV/AIDS. We need to analyze what it is so that we can respond to it, not just for the sake of those at risk, but for those who hold these positions. I mean, we have to inevitably, I think, address, say in the Schiavo case, we have to address those people who are deeply entrenched in this situation as well. There is deep fear and also great power in these issues. Yes?
As I understood the breakthrough at Bangkok, it was that human rights language created a mandate for making the treatment that was available for some, something that was due to everybody. Farmer, and you mentioned Paul Farmer, I'm grateful for that reference. In the book Pathologies of Power, the last chapter speaks in those terms. It even goes beyond that to say that the poor should have the best treatment first. At the same time in that book, he compares how Cuba dealt with AIDS to how the United States interned patients in Cuba, in Guantanamo. And he argues that Cuba was very effective because it took some very stern public health measures. And I'm wondering whether the same language of human rights and autonomy, whether that would set up a boundary on the public health end that I didn't hear you discuss, and I'd like to hear your comment on it, as to how far you go to prevent AIDS from a Cuba did not lack the political will.
Right.
And the incidence of AIDS is very low. How far on that end are you?
The question really is that when Paul Farmer writes in his book on the pathologies of power, he talks about the case of Cuba, and in order to make sure that there wasn't the spread of the virus, there was a lot of quarantining that went on there, and there was a lot of holding hostage certain populations for periods of time. And I'm being asked how far would I go on the question of human rights in this. But you know, I am trying to go through the language of human rights to do that, and I think that the way we best try to determine what is the way to proceed is to go to a discourse on human rights. I mean, I certainly am not interested in quarantining population. I actually think, as a matter of fact, that's what we are doing. Now, I'm thinking that if we gauge the language of human rights, maybe we would break the quarantining. You know, that's what I think. When I look at the world situation right now, I see that we have morally quarantined, we have economically quarantined, and we have medically quarantined those whom we perceive to be at risk. And that's what we're doing. I think the language of human rights in the secular world, but also the language of common good and social justice in our world, as well as the tradition of mercy, would enable us to break down those quarantining barriers. So I would not be interested in creating a way that those who are most at risk need to be most kept away from us in our societies.
Just in terms of that particular issue, I like very much the section of your paper where you talk about tearing down barriers and overcoming these forms of silence and overcoming these forms of judgmentalism and all of that sort of thing. And that's really, really crucial, it seems to me. Taking that and that argument about mercy, taking that argument really seriously, it seems to me, leads to a conceptualization of human rights that is basically not simply grounded on an idea of autonomy. That human personhood is not simply being left alone, isolated, kept free from outside interference and all of that. So that really opens up a whole very important domain of thinking about the meaning of human rights. But then it gets you into the question of how does the good of society place restrictions on individual behavior? And that's where the quarantine question emerges. And that's where it seems to me, when you get into the discussion about human rights, you have to start talking about something other than just the language of human rights, but getting down to the nitty-gritty about what does this language mean in particular cases? What does it mean about barriers that prevent people from getting access to ARVs? What does it mean about being able to have access to an ordinary life in society and not to be isolated and marginalized in a quarantine camp or something like that?
Right. It was
So
interesting
gets
at the Bangkok AIDS conference to hear the language of human rights used in two different ways. Almost, not all the time, but often, when it was people from the North talking about human rights, it was highly autonomously driven. For instance, at one point they were talking about microbicides. Now, we don't have microbicides. We may have them in about 7 years, right? So 7 years, more or less. And this Canadian researcher said, we have a human right to microbicides. Well, we don't have them. You can't have them. That's my only response to it. When people from the South were talking about human rights, they used the term not as a rhetorical device to say I'm entitled to this because I'm a human person. They used it instead as a way to analyze what are the goods that need to be in place to secure the benefits for our society. Not only was it social, it was analytical, and it was able to really get into a variety of questions that otherwise wouldn't be open. So the framework of human rights that a lot of people from, say, Uganda or Brazil were using was inevitably both social and analytical, rather than a rhetorical assertion of the autonomous prerogatives that belong to a particular agent. So there are different ways that you use it, but I think it will finally be what type of form of human rights are we really looking for? But that's the discussion that we're trying to get to. Nonetheless, to hear the people from the North using the word human rights, it was disarming. You had a question.
Yeah, I have a quick question. I really appreciate, I think, the strategies about bringing the discussion more to the table through institutions like the Catholic Church and educational ways as well is a great way to start at the micro level. My question is, do you think there's a way to bring that discussion in sort of a more mass way? Because one of the things that struck me was what you said at one point in time, that the idea that anyone can get AIDS, instead of scaring people, you said actually was a backlash, that it didn't work because it made more barriers, it created barriers. So I guess one of my questions is, you know, education universities is a great way to start it off, but for many people, I guess there's still not that access. And so my question is, once again, do you think that what are some positive measures to make it into a more public campaign domain kind of thing?
I think that's a great question. I think what the question is, you know, AIDS is an opportunistic virus, right? And we have to ask ourselves, where are the opportunities that we could find to do what you're suggesting? How do we get into the media to make people realize that the face of AIDS is 15 to 24-year-old young woman? That's a very common face of AIDS. How do we get that there? How do we get it on the TV? How do we get it from the pulpit? How do we get it in the grammar school classroom? You know, and so I think it is through imagination. But I think that's why I was going to the Confraternity of Divine Love. They form these communities, and it was in these communities that people use their imagination to figure out how in the concrete can we respond. You know, I'm doing a course, this is free advertisement, next fall called HIV, AIDS, and Ethics. You know, I hope a lot of undergraduates take it. I hope that those who take it figure out answers to your question, because that's the key question. How do we communicate what we're recognizing as a problem here tonight? I mean, I don't know of anybody, the third part of my essay about the barriers that are being created, I don't know of anybody who's written on that. I know everybody who's written on human rights language, people who've written on common good language, questions of justice, but not about the resistance, the active resistance. Just naming it is something, like Vince Lynch has done a book on for social work in AIDS, and how to help social workers to get there. I mean, there's a number of people who in our own disciplines have done it, but how to enter into the common culture, to make it familiar, to make it our challenge. I mean, that's what we need people from a variety of ways to say there is no patent on that. We need to have a real sharing of the imagination for that. Two more questions in the book. Chris?
You mentioned that Jeffrey Sachs in his Time magazine article talked about the progression of the consequence disease has on poverty. And Paul Farmer, you said was switch. But getting into common culture, I mean, I imagine millions of people read Time magazine. Do you think that could have been damaging to people to look at disease as maybe the fault of the individual, and therefore it's their own fault that they're in poverty, rather than more of like a social context to realize that like a macro scale poverty is causing disease, and it might bring more of an innocence to the face of things?
Yeah, but he did in that article, and also now in the book, because the article, this enormous article, The End of Poverty, is an encapsulation of the book that he's just launched. And in that, he keeps talking about how those of us not in poverty create these narratives of how through good moral standards and everything else, I'm right here where I am. You know, it's like the story of the Rockefeller family, you know. My good moral upbringing, this is where I got to where I am. And he really wants to contest, you know, the way we imagine the causes of poverty. He really wants to look at the causes of disease. In other words, he wants us to to realize how we create biases by which we explain why they are there and why we are here. And he wants to contest that. So there's something really refreshing about both the shorter essay and the larger work, in which he wants to address how it is that we manage to still insert a narrative of blame, whether we start with disease or poverty. I think he faces your question head on. And he does it with great humanizing and almost humorous effect. Yes?
I have two questions. One, do you
You're only allowed one, because everybody wants to leave.
do you think that the issues and the ethics and the publicity that genetics and cloning and stem cell research receives in that area takes away or overshadows the ethics that could be or should be given to the AIDS and tuberculosis and other kind of socioeconomic diseases? So do you think that that kind of area takes away from discussion or?
Right, I think that's one of the reasons why I was saying that once the bioethicist turns to the public health official, the narrative gets a lot more gritty, it gets a lot more ordinary. You start talking about TB and malaria, which are not as interesting as stem cell research, and you're in a world of the ordinary. I do a talk about HIV/AIDS with lots of slides that I get actually from John Fuller, and one is the top 10 causes of mortality, first in the world and then in sub-Saharan Africa. And AIDS ranks 4th in the world, and it ranks 1st in sub-Saharan Africa. On neither graph is cancer. Neither graph is cancer. The top 10 modes of killing a person, of dying in the entire world, cancer isn't there. If you were to ask an American today, what is the cause of death in the United States? Everyone would say, not everyone, many would say cancer. We don't even understand what we die of, let alone what the world dies of. And finally entering into the world of the real, because I think the public health official brings us closer to the real than the language of discourse that we see in stem cell debate. A number of us were at a meeting where we were discussing not the stem cell debate that we held here, but with other people, just the hype attached to it, all the promise it will bring, what promise will it bring? Where is the real details? Where is the concrete information? So there's a certain way that I do think a number of questions that we have are really about imagination, not the imagination that she's asking for, an imagination to help society to deal with the real, but I do think that there's a certain way that it's as attractive as our media is. Who wants to see on TV 2 minutes on malaria? Not many. But 2 minutes on stem cell research, I'm there. So how will we do that? That's why I think the real challenge of addressing this is problematic. Second.
The second point is, I'm wondering what your personal opinion is in terms of the privilege or the stable societies accepting or kind of going along with Jeffrey Sachs's what the plan that he put out, or even other ideas, or as this pandemic is growing, is there going to be, in your opinion, is there going to be the response that is needed, or are you hopeful, are you pessimistic, or?
I think what we're really looking for are a variety of voices to be raised. Again, like my answer to your question, I think we need a variety of voices that are constructively moving forward somehow to talk to different sectors of our population. When I had the good fortune to go to the AIDS conference in Bangkok. I went with John. There were 20,000 people there. I think the only theologian other than myself was Musimbi Kanyoro. There may have been one other. There was no ethicist that I met at any event. There were public health officials, there were activists, there were also, why weren't there bioethicists there? That gives you if bioethicists don't realize it'd be good to show up at a conference, or theological ethicists or theologians, at the greatest threat to humanity in the 20th, 21st century, what will it take for us to deal with the ordinary, Joe and Mary in the church, or the ordinary, Miguel and Sanchez in the classroom? It is astonishing how the academy and the church, as beacons of moral education in the world, has really not energized us on the question of AIDS.